Welcome to Fertilish, the podcast where we get real about fertility, infertility, and everything in between. I'm Laura.
And I'm Brandis. And whether you're knee-deep in treatments, just starting to ask questions, or somewhere in the ish of it all, you're in the right place.
Here we ditch the stigma, break down the science, and have candid conversations about the messy, emotional, and sometimes hilarious journey to growing a family and preserving your fertility.
So grab your coffee, your meds, or just your curiosity, and let's get into it. So we are back for episode number 15, all about recurrent implantation failure.
Yeah, I think that we get a lot of questions about implantation failure, especially as a recurrence. Obviously, it has quite the emotional toll, quite the financial toll, and physically can be difficult as well. And so it's definitely not anything that we ever want any patient to go through. But something that is very real and does exist and does happen. And I've experienced it myself. And so I definitely have an appreciation for other patients that have gone through it, because it's very difficult. You get your hopes up and you've gotten to this place where you have this beautiful embryo and, you've transferred it and you don't want to get your hopes up too much because that it couldn't work out, it might not work out. But there's this part of you that needs to remain hopeful at the same time. So you teeter on the border of remaining hopeful, but not getting your hopes up, not putting yourself out there too much. And so, yeah, it's a hard place to be.
Yeah. And, by the time I talked to Dr. Kiltz about this a lot, by the time people get to us, they've been trying to conceive on their own for so long. They've maybe done IUIs, timed intercourse cycles, or even IVF at other clinics. And so now you get here and you get to an embryo transfer and people have this thought, I think that, well, I'm doing IVF now, so this has to work. It's IVF.
Absolutely.
And it's just, that's not always the case. And even if you have a euploid or a chromosomally PGT tested normal embryo, it doesn't mean it will work or it doesn't mean it will result in a live birth. And that is so shocking to people when they find that out, because not only does an embryo have to be normal, but there are so many other, chemical reactions and different things that have to happen for that to result in implantation or a live birth.
Yeah, there could be physiological issues that could be, preventing implantation. So you could have this completely perfectly normal embryo, but it's not going into an environment that's hospitable, for implantation or, to be able to, carry a pregnancy. And so there's a lot of different factors that go into trying to, investigate the cause of implantation failure, because there's so many different nuances that it could be.
Yeah, well, and recurrent implantation failure, the definition technically of it is 3 failed euploid embryo transfers, meaning that we have tested these embryos are normal. After 3 transfers, you really should be sitting at a 95% chance of live birth. So if you've gone through 3 of these transfers and we haven't had any implantation, you officially fit the criteria for recurrent implantation failure. And so if you end up on my schedule, there's a couple of things that I'm going to look at and review. One is the type of embryo, which we just talked about. The second is, was your lining thick enough, and was it a certain structure we call trilaminar? So we like it at least 7 millimeters in a structure we call trilaminar before we start you on progesterone. Mm-hmm. Likely it was because you made it to transfer, but I do look at that. I want to make sure your thyroid is kind of within a guideline that we want it to be. And then, has this patient had either a saline sonogram or a hysteroscopy, so a uterine evaluation, within the last 6 to 12 months of doing an embryo transfer? Mm-hmm. And so those are kind of the first things I look at. If all of those things are normal, now I'm going to start thinking, okay, there's embryo. Could this person be sitting on the lower side of statistics? Are they in that 5%?
Right.
Uterine factors Are there polyps, fibroids, uterine septum, adenomyosis, which is where the uterine lining grows into the wall? Are these things there and we're not seeing it with a saline sonogram? I may suggest a hysteroscopy where we're putting a camera in and making sure that we're not missing anything. And then, there's additional testing, the ERA, Receptiva, Emma Alice, which I will go over. Did you do any of those tests?
So I did Receptiva, and it was normal for both the endometrio or the BCL6 marker, and then endometritis, and then we did. So I guess, obviously saline sonograms, HSGs, didn't do like an Emma Alice, or an ERA,
Okay, so Receptiva, like Laura was talking about, checks for, it's a uterine biopsy. So you're typically awake for it. It's checked, most of these are checked in the luteal phase of the cycle. So after the lining has been exposed to progesterone, we're taking a biopsy of the lining. Receptiva checks for BCL6 and CD138. So BCL6 is a protein that can be associated with endometriosis or possible hydrosalpinx, which is dilated tubes. And then CD138 is a protein associated with endometritis, which can be chronic infection, inflammation of the uterus. If you come back positive for BCL6, we are typically treating you with 60 days of hormonal suppression before a medicated embryo transfer. So Orlissa, Myfembry, Lupron, injections with letrozole to kind of calm down any inflammation that could be going on before doing a transfer. If you come back positive for CD138, we're treating you usually with 2 weeks of doxycycline. The ERA, we've kind of talked about this before, stands for endometrial receptivity analysis, and we put you through basically a mock transfer cycle. And then at the time when we would normally do the embryo transfer, we're doing a uterine biopsy, and we're seeing if your uterus is basically receptive based on the amount of progesterone hours. So you'll either come back receptive, meaning that at the time we did the biopsy, when we may have otherwise done the transfer, the uterus was perfect. You're sitting at receptive. Or post or pre-receptive, meaning that you need a couple more hours or a few less hours of progesterone. This has kind of fallen less out of favor, especially we're not doing this as a first-line test. But if we do have recurrent implantation failure and things are coming back normal, it is a test I'll usually recommend. Emma Alice really just looks at the microbiome of the uterus. So if there's too much bad bacteria, if there's not enough good bacteria, which I usually tell patients just to start a women's probiotic. But yeah, those are kind of the additional tests.
I think it's important to note that, obviously, none of the test is, 100% certain. So if a provider, let's say you have a Receptiva and a provider still suggests that you do, 60 days of suppression, it is not the worst thing in the world. I've done Lupron more than once. It's not my favorite, but it's not, it wasn't nearly as bad as I thought it was going to be. I kind of braced myself for the mental health ramifications that I thought I was going to experience. 'Cause I'm just super anxious person without any help.
Same.
And so, I was really worried about that. And so I had actually asked Dr. Kiltz, instead of doing Lupron Depot, can I just, which is, for those of you that don't know, it's a shot that's it lasts you 30 days. So essentially if you're having to do, 60 days of suppression, you would take 2 injections. And I was worried that I was going to have 30 days worth of medication in my system that I couldn't get out. And there was nothing I could do about it until it just kind of wore off if I was whew, this is not for me.
Yeah.
So I was hey, do you mind if I just do the daily injections of Lupron? And he was no, that's fine. And so that way I felt I had more control over which I don't mind taking injections. That never bothers me. So like for people who are just like, ooh, I don't really love shots. Like I've had to do too many of them with IVF anyways. That might not be the route that you want to go. Because it is obviously another daily injection.
Yeah.
But it's with an insulin needle. It's
Yeah.
sub-Q in your tummy. You barely feel anything. So it's not nothing terrible. But it just helped me because I felt like I had more control of it. Like if I could not handle, I was about to go jump off a cliff or something. I was like, I want to be able to be like, no more of this mid. We got to try something else.
Yeah.
But it wasn't nearly as bad. Honestly, like the worst part of it for me, which obviously everybody's experience is different, was hot flashes at night. I like got one of those little neck fans that blows in your face, and it helped quite a bit. And then like some like kind of bone joint achiness, that I could definitely tell while I was on the medication. So, you kind of feel sore, kind of feel like a little stiffer than normal. That was probably the worst part of it for me. I know, again, everyone's results may vary, but I guess the point is that like, even if you have a negative Receptiva test, there may be other factors that your provider feels like it's best for you to do some suppression. And it would be better to like do the suppression to be on the safe side, rather than to risk losing another embryo.
Oh, 100%. And you bring up a good point. Sometimes, if we get back that Receptiva test and it's negative, that's not 100% test. I mean, the gold standard is still a laparoscopy, which is a surgery, but laparoscopy has kind of fallen out of favor if we're just doing it for diagnostic purposes for fertility. And so if you have symptoms of endometriosis, you have super painful periods, you have pain with sex in certain positions, these are all things that, point me to think, are we missing something? Or on the other side of that, everything's come back negative. Do you have silent endo?
Yeah.
These are things that maybe often get overlooked. And so, you know what? Let's just treat it, like you said. And so many times, you can have horrible symptoms of endometriosis and have a laparoscopy and there's a tiny little speck of endo. Or you can have a tiny speck and your symptoms are horrible. And so the pain you do or don't have does not correlate to the severity of endometriosis. So another important point, and I'm glad you brought that up.
Yeah, and there's only so much that like we can, that like pathologists say like a definitive diagnosis of adeno can only be determined by hysterectomy. And so like we use the tools that we have to best ascertain like what we think is going on. But unfortunately there are limitations. And so in order to be able to like not risk losing an additional embryo, sometimes it's better to treat on the front end. Because there's no harm in, or I guess the risk definitely don't outweigh the benefits.
Yeah.
And so like, something like suppression for 60 days, yes, it's a pain in the ass to have to wait 2 more months. Like, yes, like I was just like, oh my God, this is never ending, you never want to wait 2 more months.
Yeah.
Like you wanted this to be, you wanted this to have happened 3 years ago.
Yeah.
But at the end of the day, like waiting 60 days, doing the suppression and like feeling good about moving on to the transfer, it is really like worth a lot.
Yeah. And there are other things we look at too, on top of like when we say inflammation, adenomyosis, endometriosis, endometritis are things, but even, do you have rheumatoid arthritis? Do you have autoimmune conditions, Hashimoto's? These are things that CNY, addresses usually right off the bat, depending on your situation, but we have immune protocols. There is a thought, and there's so much infertility we don't know, and it's constantly changing.
Yeah.
And so what I recommended to somebody 3 years ago, I may recommend something different because, and you should be keeping up your providers should be keeping up with new things, so they shouldn't always be practicing the same.
Yeah, we should all be evolving.
Yeah, so sometimes people are like, you said last time. I'm like, no, it changed. But, if you come back and, you have autoimmune issues or things going on, we will put an immune protocol on, because there is a thought that the immune system can play a role in, is it keeping the embryo from implanting? Is it recognizing the embryo or the baby as a foreign body and it's attacking? And so we do also incorporate here medications that can help with that. So, like I said, we're looking at the uterus. Is there a septum, polyps, fibroids? We're looking at the embryo. We're looking at the environment. But honestly, more times than not, the issue is the embryo and issues with the embryo. And it's not really protocol or other things. So many times people will do even just a transfer. And they'll say, do you think I should change my protocol? And so many times it's an embryo issue, and we know this because the cumulative live birth rates go up the more euploid transfers you do, and so that's kind of one thing to point out.
Yeah, I mean, I think that like we've talked about this before, like the more times that you try, the closer you get to the goal, and that's essentially like the layman's term, or the layman's like breakdown of what you just said, like, but, I think that you've also mentioned in previous episodes before, like, if we keep coming back with the same results, at a certain point, I do feel like as a provider, it's my goal to like kind of reassess and say, hey, like, maybe let's try this next time or this. And so, and I appreciate your willingness as a provider to always look at our patients and say like, hey, okay, like, well, this is not working. Like sometimes maybe we need to add on this or add on this. And maybe we don't know a definitive reason as to why this is not working, but it's not going to hurt anything to add on these, this medication or this, and it may yield us the result that we're hoping for.
Yeah, and if you're sitting at a point where you've done, transfers and they've been unsuccessful, do not pass go. Do not keep doing embryo transfers, doing what you've been doing. Have a conversation with your provider about these tests. What are we missing? What should we change? Your history, if you've had prior losses, if you've had 3 transfers, do you need more embryos now?
Yeah.
Review your goals. Do you need to do another egg retrieval? Is this a good time to start working on lifestyle factors for both you and partner? One thing that drives me nuts, and I will always be the stickler for this, is if people have done multiple euploid transfers, sometimes they'll say, well, it didn't work the past 3 times. I didn't want to wait for a follow-up talk, so now I'm going to transfer 2 euploids. And that,
we worked so hard to get those.
I know, I'm like, well, what if something's being missed and we haven't, like, caught it, and now you're just wasting 2 euploids, and you're financially, emotionally, your time is precious. And so many patients will get mad at me for this, and I know they do, but it's like, well, it's my decision. It's 100% it is.
Sure.
I will never, though, advise you do a double euploid embryo transfer ever. But coming from a provider standpoint where I want you to be nothing but successful, I want to make sure we're not missing anything. And so for me, the answer is never, well, let's just add more embryos. No, let's figure out what's going on so that way when we do your next transfer, it's successful.
Yeah.
Because if there's some blood clotting disorder that you have, you do have endo, there's horrible inflammation in there, and we're just keep putting embryos in, that's not a way to success necessarily.
Yeah. I mean, as a patient, I have always been terrified of transferring 2 embryos at a time. And it's not because of, like, the twin aspect, although, like, I understand that there's additional risk. And I talk to people about that all the time. Like, there's additional risk of, like, pregnancies of multiples to the mother and to the babies. And so, obviously that's an additional risk. But I've just always been terrified of like, what if something wasn't okay, like with my uterus? What if like the environment wasn't the best place for the embryo to go? I would much rather lose one embryo than two.
Mm-hmm.
And so, and maybe that's coming from like the perspective of like, I don't get a lot of embryos in the first place. Maybe I would feel different if I had 15 embryos hanging out up here, and I would be like, oh, okay, well, I can
Yeah.
transfer two. But I guess coming from a place where I like don't have a lot of embryos in the first place, like I've always just been terrified to like lose two at one time.
Yeah.
And so I think that that's something to like, for people to consider as well, that like, if that cycle is not, if everything's not aligned and you're, and ready for implantation, are you comfortable with losing two embryos? Would you rather have lost one and have this embryo to like take something away from
Mm-hmm.
this cycle? What have we learned? What do we need to do for the next cycle? And then you still have this embryo to transfer in a subsequent cycle.
Yeah.
So that's, definitely something to consider. Obviously, like we allow patients to transfer more than one embryo. We do allow for double embryo transfers. There are some, guidelines that we like to try to follow with ASRM. And, we do have consent forms that patients have to sign, understanding that they have read and they understand the risk of a pregnancy of multiples. And, they need to speak to their provider about that as well. And so, but we do give patients that autonomy. But, I think that's something to consider if you've been in a place where if you've had,
Mm-hmm.
implantation failure, that, or even if you haven't, and this is your first transfer, but you only have two embryos.
Yeah. And now yeah. Well, and another point to that is not only, yeah, you can lose two embryos, but we've had patients where they both implant, but one's in the tube.
Yeah.
And so now we're treating the ectopic pregnancy with surgery, and then a couple weeks later, the one in the uterus doesn't survive,
Yeah.
or because embryos can split. It's a high order multiple pregnancy, and so, they're saying this is dangerous. You need to reduce, or there are so many things. And I think for me, when I like counsel patients on this, I get a lot of like people coming on the defensive, and like I said, it's my decision. But on the other hand of that, like for me, it's so important to myself, and I told myself when I took this job that I would never want to put somebody in a position to where they're going to have to make a hard decision
Yeah.
because of something I did.
Yeah.
And so that's something I've kind of stuck by. And so there are transfers that I'm said, I'm not comfortable doing this, but I will see if somebody else is, because I don't want to put you in a bad position. And sometimes that comes off as like, well, we'll go to somebody else, and that's fine. And it is entirely your choice. But for me, it's just so important that we know what the problem is. We're addressing it. We're not, putting multiple embryos in, and you and baby are in a safe spot and position.
Yeah, and that I'm sure, and you've at the very minimum had a conversation with them about
Yeah.
like all the risk, whether that is, another failed transfer, or a pregnancy of multiples, or, whatever the case may be. Obviously in life there's risk with everything, like nothing is without risk. And so those are things that we take risk every day, multiple times a day, like every time we drive down the road, but I think that it's when you're at a juncture of your life that's so big, and you're so emotionally invested, you're so physically and financially invested, and it's, I'm sure taking a toll on you, as well as, your partner, if you're going through treatment with a partner. And so, yeah, like I think that like the least we can do for you as your providers is supply you with the information and the data to back that up, and, to do our best to give you all the information so that you are able to make the best decision for you.
Yeah, no, for sure. And, I think it's more rare, but we have had patients where, we have tried everything. We've done a hysteroscopy, they've done a laparoscopy, they've done immune 4 protocol. They've done all the things, all the tests, everything comes back normal. We've suppressed, we've treated them with antibiotics, we've done all the things, and we had euploid transfers, and it's just not working. Sometimes I've even told patients, like, I honestly, at this point, we've thrown everything at it. You need to maybe try and see a reproductive immunologist, an RI, which those are, I know they're super hard to get into
And they're
expensive.
very few and far between. Yeah, there's so few of them.
So, that's sometimes an option as well. I know some people go and love it and have found their answers there. And then, sometimes it's like, I don't know, maybe we need donor egg or embryo. Maybe you need a gestational carrier or a surrogate. Usually it's a gestational carrier. That way you can use your egg and sperm in a different person. But sometimes we don't get answers, and that's so frustrating. But like I said, it's such a new field that we learn stuff every day, I feel like.
Yeah, no, absolutely. And it is hard to like kind of get to the point to where for a lot of patients to where they can accept like either someone else carrying their child or being comfortable with utilizing donor eggs or donor sperm or donor embryos. And so like, obviously none of this looks the way that you imagined it when you thought that you were going to try to have a baby. Like none of it does. And there's always a new disappointment.
Yeah.
Like, it's always a new frustration, a new disappointment, something else that costs more money. Like, it's just like all the things all the time. And you're just like, Jesus Christ, like, what next?
I know.
But, I think that like, and I think I've probably said this a million times, like, just trusting your provider, making sure that you have an open rapport with them, that you're like telling them all of your concerns, all of your fears, because the more that they know about you, the more that they can help you. And so, and sometimes there are concerns that like maybe you're concerned about that you don't have to be concerned about, so that they can kind of like ease your fear about that, or just help to navigate that journey for you, whatever twist and turn that takes you on. But I mean, obviously, like all of this, like, if that's something that you kind of get to that juncture with a patient where you're like, hey, like, I think that you should consider this, whatever this next step looks like, that's, it's not desirable for any of us to have to now try something that's more costly or, less looks like, what you had hoped that this would look like. But it's for good reason, because sometimes it does take those things. And there have been, many babies born from surrogates and gestational carriers, and many babies born from donor eggs, embryos, or sperm. And that was like the thing that it took. But also many babies that have been successfully brought into the world because we added, an immune protocol to them. We added, they needed a blood thinner, or, they needed, whatever the case may be.
Yeah.
So, we have those immune protocols in place for a reason, which is something that like is really special about CNY, that we do have those that, our patients have access to without doing tens of thousands of dollars worth of testing. They are recommended probably a little bit different by different, from provider to provider, and from patient to patient, and with good reason. And some of it can feel a little overwhelming or a little scary. And sometimes I feel like that, OBGYNs are a little hesitant, but one thing about Dr. Kiltz that I adore, like, I've encountered situations where OBGYNs were like, wait, why is this patient on all of these meds? This is like, I'm concerned, some of these medications are not medications that I would, normally have my patients on that are pregnant. But this is not a normal situation, and how they got here is not a normal situation. And so sometimes it takes abnormal tools or out of the box
Yeah.
tools to be able to remedy an out of the box or an abnormal situation. So Dr. Kiltz has been wonderful about, he'll be like, yep, just like let me know when they're available, give me their phone number, and calling those OBGYNs and saying like, hey, you know, these are what these protocols are for, you know, this is how they help patients,
Yeah.
explaining them in depth, and going into the why,
Yeah.
you know, behind the medications. And so, you know, if we ever have patients that like their OBGYN's like, whoa, like why are you
Yeah,
on all
which
these
is common.
meds?
Yeah.
That's right. You know, please feel free to reach out to CNY, and like we will definitely be able to, you know, bridge the gap between your provider and your two providers, us and them.
Yeah.
To be able to help them to better understand like why are you are on this specific medication. We don't expect you to know all the things and all the whys, and be able to tell your OBGYN that like we're here to help.
Yeah. Well, and I think you kind of hit the nail on the head when you said it's so important to pick a provider that you trust, because you know you should be able to say your concerns, say your goals, say what you can and will tolerate, and then what you won't.
Yeah.
What your boundaries are. You know, don't be afraid to speak up and ask these questions and speak up for yourself. There are so many times, because I have so many friends and family that have now come through CNY because I work here. And they're a part of all like the patient support groups. And so sometimes they'll screenshot me things. It's like, hey, I had a follow-up talk with Brandis today and she recommended I do this test. And they'll like say, oh, I meant to ask this. So can anyone explain to me this and tell me why she may have recommended it this way? And then it's like frustrating, because then people will chime in as to why I may have suggested something.
And they're trying to read your mind, which there's no possible way
and I'm
that
like,
they
no,
can, or
that's not at all why I suggested
like
it.
send me a message.
Yeah, like if you forget to ask, I'd rather you send a message in your portal and just ask. Or if, you know, hey, she recommended this biopsy, but I'm terrified I'm not going to do it. Well, tell me that.
Right,
because
right.
I may offer you, like, let's do it under anesthesia. Or, hey, I can't do this test because it's too pricey. That's fine. We'll just suppress you then. We could just do suppression, and you don't need to do the test. You're not having... So communicate those things directly to your provider, and you should feel open to say those things. And if someone takes offense to it or is angry back for whatever reason, just get a new provider. Like, it's not a big deal.
Yeah.
Find someone that you vibe with, and no one really takes offense to that.
Yeah, no, I recently found myself like apologizing for like wanting to know the why behind my own, like for something with my own protocol or whatever with Dr. Prakrashi, and she was just like, Laura, what? Like, why are you apologizing to me? Like, no, these are the things you're supposed to be asking me. Like, if you have questions that you're not asking me, like, that's what you're going to be in trouble for, you know? And so, like, I think that I think that our providers are wonderful about, like, understanding that, like, first of all, it's a whole lot of information. It can be real overwhelming, and, like, you don't do this day to day, like, you know, for like career, and you like didn't go to school for years to like get to this point. So like, if we are speaking in a way
that you don't understand,
please let us know, because I think it's easy, like when you do use the verbiage quite frequently, that like sometimes we might get caught up in the like not putting it in a way that's like understandable, and so it like point that out to you know, your provider if there's something that you don't understand or you need to like know more information about. And then also, like, if you have fears about that, or we would much rather you say like, hey, that kind of scares me, like, is there an alternative? And maybe that, like you said, a procedure could be done in an alternative manner, or there's an alternative to that procedure or protocol or medication or whatever, or hey, my insurance is not going to pay for this. It's going to be $3,000. Like, that's out of my wheelhouse right now. Like, is there another, you know, like alternative to this? And there may be another medication that will work just as well in your particular circumstance that your insurance may pay for and may cost you $20. So, it's not a one size fits all. And so, so I think those are important things to like point out to your provider, as to like we would never want you to just like say, okay, well, that's what they
Yeah.
wanted me to do. I can't do that. Like,
We'll just keep doing transfers.
right. Or because we want you to have success, just as much as you want to have success. And so like the transparency
Oh,
is,
yeah.
is like key on both sides.
Yeah, no, 100%. And so I think, if you're having recurrent implantation failures, unsuccessful, recurrent miscarriages, make sure that instead of adding embryos or just keep on doing transfers, that you stop and you schedule a follow-up talk with someone that you trust. And even if that means waiting a month or two, it's worth it, because one, that time's going to go by even if you do a transfer and it's unsuccessful again.
Yeah.
If it, it's going to result in another miscarriage, then you have to do a DNC. All of these things cost time, money, are emotionally
Heartache.
and physically exhausting. And so I know sometimes it's a wait, but it's worth it, because you're kind of double checking everything. We're making sure nothing is being missed, and you're not wasting embryos that you worked really hard to make.
Yeah, absolutely. And, And then, like you said, the emotional toll of just like the whole process of another loss, is more difficult. And so, waiting another cycle, I really wanted to transfer an embryo in July, but I'm going to wait one more cycle and update my HSG like a good girl.
Yeah, do all that. Yeah, and if there's any preconception testing, I know you didn't skip it, but if there's any preconception testing you skipped and you chose not to do, maybe go back to that and say, hey, maybe we'll do this test now, because it is, the more variables and the data we have, the more we're able to help usually.
Yeah, that's a conversation. I'm so glad that you brought that up, because that's a conversation that I've had so many times when people are like, I had an SHG a year and a half ago. Like, do I have to repeat this? Or I had an HSG 2 years ago and like my tubes are fine and like I really don't want to do it again. And I'm like, girl, me either. I get it. Like, I don't want to do it again either. But like I would much rather go into a transfer knowing that like my testing was updated and everything was cool, rather than like lose an embryo or 2 embryos or 3 embryos and then be like, shit, like what information might I have known before I did these transfers if I would have done these super simple tests, that might have changed the course of like my protocol or my transfers, that I might now like have a different trajectory. And so I would much rather know like it's done and feel good about moving into that transfer than be like, oh no, what if I would have just done the test and then, so, yeah, like I get it. They're not fun. Like, and it just, we've talked about that before. Like, it's not my favorite thing to do. It's not the way that I just like choose to spend a random Wednesday afternoon or anything, but I'd much rather do that. Get it out of the way. It's a short little procedure, like, and then move into that next cycle, And the good thing about it is that you're not going to do a transfer the day, the same cycle that you have an HSG. So go have a drink afterwards.
Yeah. Well, and money wise, I feel like a lot of people, whether it's, and we offer financing, but whether PGT is too expensive or testing is too expensive, well, now you've spent way more money in transfers that have been unsuccessful than you would have if you just did the testing and then just did the transfers with, kind of all the data we could have had.
Yeah.
And so something to think about for sure.
Absolutely. And even if you don't have fertility benefits, a lot of times your health insurance will still pay for an SHG or an HSG, even if you don't have like coverage for IVF or, coverage for your meds or whatever. Even if all that's out of pocket, a lot of times like it will cover that. So it will cover the testing. So, it's possible that you may need to get the order from your OBGYN instead of, whatever you need to do to be able to get it covered. Then I suggest you, explore your insurance benefits, see what's applicable to your policy. We have this like super amazing handy tool on our website under the resources tab. It's called like a financial welcome packet. And in there is a sheet that you can actually like utilize to contact your insurance company, and it has like all the questions to ask, all the things, and that way it just like gives you so much information. And it's very similar to a sheet that providers use when they call your insurance company to verify benefits. This is the information that we need to know too, and it helps break it down for you. So if it's something like that where you're just like, oh, this, I've been told that an HSG at such and such place was going to cost me. I mean, I've heard crazy amounts of money,
Oh,
$2,000,
yeah.
$2,500. We'll use that sheet, call your insurance, see if there's a way that you can get it approved to where, your OBGYN orders it, or whatever the case may be that needs to happen for your insurance, so that you can get it approved and maybe pay a $50, copay or
Yeah.
something, or maybe it covers it all.
Yes. So, yeah. No, sometimes people end up spending more money and time trying
Yeah.
to cut corners than they would if they just did it. It reminds me of like the saying of like when somebody's craving like a peanut butter cup, and so instead of eating the peanut butter cup, they'll go buy sugar-free candies, and then they'll eat that bag, and then they'll have an apple, and then and it's like, okay, you ended up eating way more calories than you would have if you would have just had the peanut butter cup, like, and got it out of your system. So yeah, I would do the testing, do as much as you can with as much data. That way we're going into it, hopefully being successful.
Yeah. The more information, the better. And not only for yourself to feel confident and moving forward, but the more information that your provider has, the more information that they're able to or the better that they're able to guide you on, having that information. And so, yeah, I mean, it's possible that your tubes were clear 2 years ago, but it's possible that they're not now.
Yeah.
Maybe you have hydrosalpinx now. Who knows? But that could very well be a reason that your embryos are not implanting. You've got fluid that's toxic to them.
Yeah, hydrosalpinx can actually decrease your chance of pregnancy by up to 50%. And so if you have that, get them removed. Or get that tube removed at least.
Yeah, and that's one of the major reasons that we do an HSG is that's what one of the things that we're looking for, and so these pieces of tests, they're very beneficial and very informational, and so if there are things that haven't been updated for a long time, if there are things that maybe you did skip over initially, and you're experiencing recurrent implantation failure, then I think those are things that you should revisit and really consider doing.
Yeah. Well, I hope, this episode has really helped people in this position. One, sorry you're even in this position because it sucks. But, I hope this was really helpful in helping you guide the conversation with your own provider of maybe what tests you need to ask for. If you want a referral to a reproductive immunologist, hopefully this helps you to advocate for yourself a little bit more and go for any extra needed testing.
Absolutely. And, we're here for you, regardless of whatever decision that you make next. We are here for you, not only as recommenders of protocols, but support systems. So many people at CNY have been on their own fertility journey. And they understand how hard it is, how difficult it is, and are here to love on you and support you, and just let us know what you need from us.
Yeah, and if you've been in this position and now have a baby and you did something, a test that gave you answers, or decided it was really the end of the road and you wanted to adopt, or you didn't adopt, or this is part of your story, we would love to hear it. If you want to share it, you can always share it on our Jot forum. You can always message us on Instagram. We're pretty accessible.
Yeah, absolutely. cnyfertility.com. So on our website, /fertilish. And you can always view episodes of our podcast there, read a little bit more about Brandis and I, and submit questions, comments, suggestions, stories, funny, embarrassing, heartbreak, whatever it is that you feel that you need to share with us, we would love to hear it.
All right. Well, we will see you guys next week.
See you next week.